Assessment of aortic valve disease is a common referral to the echocardiographic laboratory. The addition of Doppler techniques to standard two-dimensional imaging permits non-invasive assessment of the hemodynamics of aortic valvular dysfunction. In particular, the ability for the echocardiographer to accurately determine the severity of aortic stenosis is having a profound impact on clinical management of these patients. In this tape, we will first discuss the 2D diagnosis of congenital abnormalities of the aortic valve. This will serve as a lead-in to the echocardiographic assessment of aortic stenosis, and we will conclude with a discussion of the utility of 2D and Doppler in aortic regurgitation. Congenital abnormalities of the aortic valve are best diagnosed utilizing the peristernal short axis view. You will recall from tape number 1 that the cusps of a normal aortic valve form a letter Y configuration in diastole. This is the left coronary cusp, right coronary cusp, and non-coronary cusp. In systole, the three cusps separate at the commissures, resulting in a triangular orifice. Before making a confident diagnosis of three-cusped valve, this systolic triangle must be identified. This specimen is a bicuspid aortic valve, which is one of the most common congenital anomalies. In a Mayo Clinic series of 21,417 necropsies, Drs. Eric Larson and Bill Edwards found a 1.37% incidence of bicuspid aortic valve. Note that the two large cusps are quite redundant. This ridge of tissue is a raphe, a frequent finding with bicuspid valves. This is a peristernal short axis view of a bicuspid aortic valve. Although there are only two commissures, here and here, the raphe gives the valve a Y appearance in diastole, mimicking a three-cusped valve. In systole, it is apparent that the point at 1 o'clock represents a raphe rather than a true commissure, because the anterior cusp opens as a solid, complete structure and does not split at the raphe. The commissures can now be confidently identified at 10 o'clock and 5 o'clock. The valve orifice has an oval football or fish mouth appearance. The location of the commissures may vary from patient to patient, but this is the most common orientation. Regardless of the orientation, the diagnosis of bicuspid valve is made by demonstrating the oval systolic orifice. Congenitally unicuspid valves are stenotic from birth. In the previously mentioned necropsy series, the incidence of unicuspid aortic valve was 0.075%. This is the single commissure, and the single cusp extends around the entire aortic circumference. Unicuspid valves open with a doming motion. In short axis, note that the orifice is small and eccentric. This is a peristernal short axis view of a unicuspid aortic valve. In systole, note the single commissure and the eccentric orifice, which has a teardrop appearance. Even less common than the unicuspid aortic valve, this is a quadricuspid aortic valve. In their series, Drs. Larson and Edwards found a 0.014% incidence of quadricuspid aortic valve. 3 of the cusps are normal sized and in their usual locations, while the extra cusp is much smaller. These valves are frequently insufficient and may also have an increased tendency to calcify and stenose. This is the parasternal short axis view from a patient with a quadricuspid aortic valve. This is the left coronary cusp, and this is the right coronary cusp. There are two non-coronary cusps, one in the usual position, and this small extra cusp. In systole, all four cusps have opened. Because the fourth cusp is so small, the valve has a triangular appearance. This is another example of quadricuspid aortic valve. Here the four cusps are of approximately equal size. Therefore, in diastole, the valve closes with a letter X appearance. Using a frame grabber, we have now captured and simultaneously displayed the opening motion of a normal three-cusped valve, a bicuspid valve, a unicuspid valve, and a quadricuspid valve. The unicuspid aortic valve is intrinsically stenotic and also has a tendency to calcify even as early as the second and third decades. Bicuspid aortic valves also tend to fibrose and calcify, with stenosis resulting most commonly in the fifth and sixth decades. This is rheumatic aortic stenosis. Note the commissural fusion. This was once the most common cause of aortic stenosis, but the incidence has declined. Currently, the most common form of aortic stenosis is the so-called senile variety, in which heavy calcific deposits form on the leaflets of a three-cusped valve. In assessing patients with aortic stenosis, we utilize two-dimensional echo to establish the valve morphology, to determine the extent of calcification, and to assess valve mobility. 2D echo is also useful for assessing the degree of left ventricular hypertrophy and for determining left ventricular systolic function, while Doppler echocardiography is utilized for assessment of hemodynamic severity of aortic stenosis. This will be discussed in further detail. This is a heavily calcified aortic valve in short axis. Often, as in this case, the degree of calcification obscures the valvular architecture. The valve clearly demonstrates reduced mobility, but scanning the valve fails to reveal an orifice that can be traced. 2D echo alone is not sufficient for confidently determining the severity of stenosis. Continuous wave Doppler interrogation of the stenotic aortic valve yields an accurate assessment of the pressure gradient across the valve. In this case, an apical transducer location is being utilized. The maximum velocity is 5.2 meters per second. From the simplified Bernoulli equation, we know that this velocity corresponds to a maximum instantaneous pressure gradient of 108 millimeters of mercury. It is important to understand the difference between Doppler maximum instantaneous gradients and CAS peak-to-peak gradients. The peak-to-peak gradient is used as a marker of severity of aortic stenosis by many catheterization laboratories. This has come about through convenience. The peak of the aortic pressure is simply subtracted from the peak of the left ventricular pressure. You will note that the peak-to-peak gradient is a non-physiologic parameter, representing non-simultaneous events because the peak aortic pressure occurs later than the peak left ventricular pressure. On the other hand, the maximum instantaneous gradient, which is derived from the maximum Doppler velocity, is a physiologic gradient, representing the maximum instantaneous difference between the left ventricular and aortic pressures. Remember that the maximum instantaneous gradient will always be greater than the Cass peak-to-peak gradient. The mean pressure gradient is the sum of the instantaneous gradients occurring throughout systole divided by the systolic ejection time. The mean gradient between left ventricle and aorta can be precisely determined from the Doppler spectrum. This is the gradient that we highlight in our report to referring physicians. The mean gradient can be determined by selecting multiple velocity points along the Doppler spectrum and converting each velocity point to a corresponding instantaneous gradient utilizing the Bernoulli equation. You then simply sum these instantaneous gradients and divide by the number of data points to arrive at the mean gradient, which in this case is 75 millimeters of mercury. Determining the mean gradient is much less tedious if the echocardiographic instrument is equipped with a Doppler calculation package. In this case, the Doppler velocity spectrum has been traced and the instrument has calculated the mean gradient, 60 millimeters of mercury. In general, a mean gradient greater than 50 millimeters of mercury signifies severe aortic stenosis. It is critical that the gradient information which we report to the clinician is derived from the maximum velocity obtainable by Doppler. This will occur only when we have oriented our Doppler beam so as to minimize the angle theta. In order to accomplish this, we must inspect the valve for multiple transducer locations. In most cases, the maximum velocity will be obtained with the transducer either in an apical or right peristernal position. In about 15% of cases, however, the maximum velocity will be obtained from an alternate position. Therefore, we recommend that a methodical approach be utilized with inspection of the aortic valve from subcostal, right supraclavicular, suprasternal, and high left peristernal positions, in addition to the apical and right peristernal positions. This Doppler information was obtained from a 75-year-old female with aortic stenosis. A nice, complete Doppler envelope has been obtained using an apical transducer position. The spectrum has been traced. The maximum gradient is 108 millimeters of mercury, and the mean gradient is 64. The same patient was rolled to the right lateral decubitus position, and the Doppler transducer was tried in multiple right peristernal positions. The maximum velocity signal was obtained in the third intercostal space. This envelope is significantly larger than that obtained from the apical position. Here, the maximum gradient is 153 millimeters of mercury, and the mean gradient is 97. It is occasionally possible to visualize the jet of aortic stenosis with color flow imaging. This is most often accomplished in young patients using a suprasternal transducer position or, as in this case, a high right peristernal transducer position. From this position, the aortic valve has been identified by 2D echo, and the turbulent aortic jet was clearly identified by color Doppler. The color jet was then used to guide the placement of the continuous wave cursor. This patient has mild aortic stenosis with a maximum velocity of 2.8 meters per second. When the Doppler examination for aortic stenosis is performed methodically, an excellent correlation is obtained with gradients measured in the catheterization laboratory. In a Mayo Clinic study, Dr. Philip Curry examined simultaneous Doppler and catheterization data obtained from 100 adult patients with aortic stenosis. This is one example from his study. In this patient, the maximum aortic velocity was obtained from the apex and was 5.1 meters per second. This calculates to a maximum instantaneous gradient of 104 millimeters of mercury. The maximum instantaneous gradient from the pressure curves was 103 millimeters of mercury. Note that the MIG is greater than the Cass peak-to-peak gradient, which was 87 millimeters of mercury. Not displayed here are the mean gradients, which were 74 millimeters of mercury from the Doppler velocity spectrum and 69 millimeters of mercury from the pressure curves. For the entire group of 100 patients, there was an excellent correlation between the maximum instantaneous gradient obtained from the invasive study and the maximum instantaneous gradient derived from the non-invasive Doppler velocity information. There was also an excellent correlation when the mean gradients measured in the cath lab were compared to the mean gradients derived from the Doppler velocity spectra. This figure from the same study illustrates the useful general rule that the mean gradient closely approximates the peak-to-peak gradient, with significant discrepancies occurring only when dealing with the highest gradients. Pressure gradients do not always accurately reflect the severity of stenosis. For a given degree of aortic stenosis, the pressure gradient will vary with changes in cardiac output. Therefore, in cases of aortic stenosis, we not only obtain the maximum instantaneous gradient and the mean gradient, but we also calculate the aortic valve area and the ratio of the velocity in the LV outflow tract to the velocity in the aorta. These last two do not vary significantly with changes in flow. The derivation of an equation for Doppler-derived aortic valve area requires echocardiographic determination of volumetric flow. You will recall from tape number 2 that volumetric flow can be determined by combining 2D and Doppler measurements. This is a schematic of a Doppler velocity spectrum from the left ventricular outflow tract. The area under the systolic velocity curve is referred to as the TVI, or time velocity integral. Integrating a velocity curve yields distance. Therefore, the TVI represents the distance that blood travels per stroke. If we measure the diameter of the left ventricular outflow tract by 2D echo, we can calculate its area. Multiplying this cross-sectional area times the TVI yields the stroke volume. In this schematic, the large A is the cross-sectional area of the left ventricular outflow tract, and the small a is the area of the stenotic aortic valve. The velocity and the time velocity integral in the left ventricular outflow tract are smaller than the velocity and TVI beyond the stenosis. The stroke volume will cross both the left ventricular outflow tract and the stenotic aortic valve during the ejection period. Therefore, flow in the left ventricular outflow tract must be equal to flow across the aortic valve. This mathematical expression, which equates flow in the left ventricular outflow tract with flow across the aortic valve, is referred to as the continuity equation. From the foregoing discussion, we calculate flow in the outflow tract by multiplying its cross-sectional area times its TVI. Similarly, we calculate flow through the aortic valve by multiplying the aortic valve area times the aortic TVI. Rearranging the equation, we see that the aortic valve area can be obtained by multiplying the cross-sectional area of the left ventricular outflow tract times the TVI of the outflow tract divided by the TVI of the aorta. It has been shown that the procedure for determining aortic valve area can be simplified without sacrificing clinical accuracy. Since the ejection time is the same in the LVOT and aorta, the peak velocities in the LVOT and aorta can be substituted for their respective time-velocity integrals. This yields the simple equation that can be used in daily practice. The aortic valve area is equal to the cross-sectional area of the left ventricular outflow tract times the ratio of the velocity in the left ventricular outflow tract and the velocity in the aorta. Let us now review the method of calculating aortic valve area step by step, first in a schematic format and then with real-time examples. The first step is measurement of the left ventricular outflow tract diameter, which is carried out from the peristernal long axis view. The 2D image should be frozen in systole. One measurement caliper is positioned at the point where the anterior aortic cusp joins the ventricular septum, and the second caliper is placed at the point where the posterior aortic cusp meets the anterior mitral leaflet. The diameter of the left ventricular outflow tract is used to calculate the cross-sectional area of the outflow tract. The area is obtained by squaring the diameter and multiplying by 0.785. Since the diameter is squared in this calculation, any error that is made in measuring the diameter will be magnified. Therefore, it is critical that the measurement calipers are precisely positioned. The second step in calculation of the aortic valve area is measurement of the velocity in the left ventricular outflow tract. This velocity is measured by pulsed wave Doppler using an apical long axis orientation. In this schematic, we have introduced a color scheme to illustrate the important principle of blood flow acceleration within the left ventricular outflow tract proximal to the stenotic aortic valve. Blue was chosen to represent flow away from the apically located transducer. As blood in the left ventricular outflow tract approaches the stenotic aortic valve, the outer borders become stagnant, so-called dead water zones. This results in acceleration of the central stream of blood toward the stenotic orifice, as illustrated here by the color aliasing. The velocity in the central zone at this level is not representative of the velocities across the entire diameter. Therefore, we do not want to use this increased velocity in the valve area calculation. We typically advance the sample volume toward the aortic valve until acceleration is detected. The sample volume is then withdrawn slightly until a stable velocity profile is obtained. This will typically be 1 to 1.5 centimeters proximal to the valve. At this level, the velocities across the entire outflow tract are more uniform. This is, therefore, the sample volume position we want to use to obtain the velocity that will be used in the numerator of the valve area equation. Remember that choosing a sample volume position too close to the valve will yield an erroneously high velocity, which will result in an overestimate of the true aortic valve area. The third step is to obtain the maximum aortic jet velocity. For this, the continuous wave Doppler mode is utilized. While we are illustrating an apical transducer position here, you are by now well aware that the aortic jet must be interrogated from most of the previously mentioned transducer positions to ascertain that the maximum velocity has been obtained. Failure to obtain the maximum velocity spectrum will result in an underestimate of the aortic valve area. Once we have carried out steps 1 to 3 with meticulous attention to detail, we are ready to calculate the area of the stenotic aortic valve. As we noted before, the diameter squared times 0.785 is the cross-sectional area of the outflow tract. This is multiplied times the ratio of the velocity in the outflow tract to the maximum velocity in the aorta to yield the aortic valve area in square centimeters. Another potential pitfall when calculating the aortic valve area is in mistaking a signal of mitral regurgitation for the aortic stenosis spectrum. This error can be avoided by paying attention to the duration of the signals. As illustrated in this case, the systolic ejection period for aortic flow is significantly shorter than the holosystolic mitral regurgitation flow period. We will now review the 3 steps in calculating the aortic valve area using patient examples. This is a parasternal long-axis view from an 87-year-old female with aortic stenosis. We will play this briefly in real time and then freeze the image in systole. The anterior caliper will now be placed here at the junction of the anterior aortic cusp and the ventricular septum. Now the posterior caliper will be placed here at the junction of the posterior aortic cusp with the anterior mitral leaflet. The left ventricular outflow tract diameter is 2.0 centimeters. This is a parasternal long-axis view which has been expanded to focus on the left ventricular outflow tract. The aortic valve is densely calcified with greatly reduced mobility. The anterior caliper will now be positioned here. Now the second caliper will be positioned here. In this case, the left ventricular outflow tract diameter measures 2.4 centimeters. As you can see, the LVOT diameter can vary significantly from one patient to another. Remember that any errors made in the diameter measurement will be squared in the valve area calculation. It is a good practice to average the LVOT diameter from measurements on 3 separate beats. Having determined the LVOT diameter, step number 2 is to measure the LVOT velocity. This small 2D image is in apical long-axis format. The pulsed sample volume has been positioned in the LVOT just below the aortic valve. The velocity at this point is 0.8 meters per second. To ensure that this is the correct velocity, we will now slowly advance the sample volume towards the stenotic aortic valve. This slight sample volume motion will result in a large increase in the velocity, which will be evident on the spectral and audio displays. This increase to 1.1 meters per second represents pre-stenosis acceleration and should not be accepted as the true LVOT velocity. We will now move the sample volume back slightly from the aortic valve. The slight motion of the sample volume away from the valve has resulted in a large decrease in velocity from 1.1 meters per second back to 0.8 meters per second. From this, we know that 0.8 meters per second is the LVOT velocity that we should use in the valve area calculation. The third step in calculating the aortic valve area is to measure the maximum aortic velocity. In this case, all of the standard transducer positions were utilized. The maximum velocity was obtained from the right parasternal position, and the corresponding velocity spectrum is displayed here. The peak systolic velocity is 5.5 meters per second. This signal below the baseline is aortic regurgitation. This display will help you appreciate the range of aortic valve areas. Note that the base of this marker has an area of 1.22 square centimeters, which correlates with mild aortic stenosis. Contrast this with the cross-sectional area of the pencil, which is 0.5 square centimeters. This area correlates with critical aortic stenosis. Several authors have published their results comparing the aortic valve area obtained non-invasively by echo using the continuity equation with the valve area determined invasively in the cath lab utilizing the Gorlin equation. As you can see, the correlation has been uniformly excellent. These are the results that Dr. J.O. has recently published from a group of 100 Mayo Clinic patients with aortic stenosis. In this graph, the cath-derived aortic valve areas are plotted along the abscissa, and the echo-derived aortic valve areas are along the ordinate. As you can see, Dr. O's work in this large group of patients confirms the work of previous authors. The R value is 0.83. To be certain, there are a few discrepancies. Note that these occur with the larger valve areas. The discrepancies are partly due to technical limitations of the 2D and Doppler measurements. However, you should remember that the gold standard Gorlin formula is not a true gold standard. It is less accurate for aortic valve area than the continuity equation, particularly in the presence of aortic regurgitation or low output. The aortic valve area is most useful when the cardiac output is abnormally low or high. In such cases, the pressure gradient will not necessarily be an accurate reflection of the severity of stenosis. This patient has rheumatic mitral and aortic valve disease. The mitral leaflets are slightly thickened, and the anterior leaflet opens with a hockey stick configuration. The left ventricle is slightly enlarged. There is dense calcification of the aortic valve. In real time, you will see that the aortic valve has greatly reduced mobility, and there is severe reduction in left ventricular systolic function. We will now calculate this patient's aortic valve area. His LVOT diameter is 2.2 centimeters. Using the previously described technique, we have selected this sample volume position in the outflow tract. The LVOT velocity is 0.6 meters per second. For this patient, the maximum aortic velocity was detected with the CW transducer in the apical position. The maximum velocity is 2.8 meters per second, which corresponds to a maximum instantaneous gradient of 31 millimeters of mercury. When the Doppler spectrum was traced, the mean gradient was found to be 20 millimeters of mercury. For reference, the mean gradient, 20 millimeters of mercury, is listed. The LVOT diameter is 2.2 centimeters. This was squared and then multiplied by the constant, 0.785, yielding an LVOT area of 3.8 centimeters squared. The LVOT velocity, V1, is 0.6 meters per second. The maximum aortic velocity, V2, is 2.8 meters per second. This yields a V1 to V2 ratio of 0.21. In Dr. O's study, a V1 to V2 ratio of less than 0.25 was quite sensitive for detection of severe aortic stenosis. Like the aortic valve area, this ratio is independent of cardiac output. It is a useful index to follow in a given patient with aortic stenosis. It is also a very useful index to rely on when technical difficulties preclude accurate measurement of the LVOT diameter. The aortic valve area is calculated by multiplying the LVOT area times the V1 to V2 ratio. In this case, the valve area is calculated as 0.8 centimeters squared. Despite having only a 20 millimeter gradient, this patient has severe aortic stenosis. Given the accuracy with which echocardiography can now characterize aortic stenosis, invasive catheterization for valve hemodynamics should only be necessary in a very small percentage of patients. This would include the less than 3% of patients in whom the echo study is technically inadequate for determining a valve area. Catheterization will also be necessary when there is discordance between clinical data and the echo findings. Remember that in addition to accurately characterizing the degree of aortic stenosis, echocardiography also provides assessment of left ventricular function and assessment of associated valve lesions, including aortic regurgitation. We will devote the remainder of this tape to discussing the echocardiographic assessment of aortic regurgitation. Aortic regurgitation results from various etiologies, which can be determined from 2D echo evaluation of the aortic valve and aortic root. The detection and evaluation of the hemodynamic severity of the regurgitation is assessed by a combination of pulsed, continuous, and color flow Doppler techniques. The functional significance of the regurgitation is assessed via 2D and M-mode evaluation of left ventricular size and function. Therefore, the comprehensive assessment of aortic regurgitation requires a detailed 2D and Doppler evaluation. We will begin with a discussion of detection of aortic regurgitation and then discuss the assessment of hemodynamic severity. The various etiologies of aortic regurgitation will be demonstrated throughout this discussion. This patient has rheumatic mitral and aortic valve disease. Note the hockey stick appearance of the anterior mitral leaflet. Both the mitral and aortic valves are thickened. For detection of aortic regurgitation, a pulse sample volume has been placed in the left ventricular outflow tract. This is the resultant pulse Doppler spectrum, which confirms the presence of aortic regurgitation. The signal is holodiastolic, and the filled-in envelope indicates turbulence. The turbulent regurgitant flow is multidirectional, so we are able to easily detect it even from this peristernal vantage point, which is nearly perpendicular to the left ventricular outflow tract. The aortic regurgitant jet is characteristically high velocity, which results in aliasing in the pulsed mode. Color flow imaging is more sensitive than conventional PW Doppler for detection of aortic regurgitation. This patient has a bicuspid aortic valve. In diastole, we have been able to utilize color flow to detect the jet of mild aortic regurgitation. The original descriptions of Doppler semi-quantitation of aortic regurgitation utilized pulsed wave mapping to determine the length of the jet. Since the introduction of color flow imaging, we no longer use pulsed wave Doppler to semi-quantitate the regurgitation. Furthermore, we pay little attention to the length of the jet. Even mild degrees of aortic regurgitation can be shown to extend all along the anterior mitral leaflet and beyond. There is both in vitro and in vivo evidence that the most significant dimension of the jet, relative to its severity, is its width, assessed just below aortic valve level. In this case, the sclerotic aortic valve is mildly regurgitant. Note the very thin jet of aortic regurgitation that is directed along the anterior mitral leaflet. The assessment of the spatial extent of color signals from aortic regurgitation relative to the area of the proximal left ventricular outflow tract is best made using a peristernal short-axis orientation. This patient has a three-cusped valve with very mild thickening along the closing edges. In this diastolic frame, the signals from mild aortic regurgitation are encoded in shades of blue and occupy a small area of the left ventricular outflow tract adjacent to the left coronary cusp of the aortic valve. An M-mode cursor has been directed through the regurgitant jet. This is the resultant color M-mode, with a thin jet of aortic regurgitation occupying the lower portion of the left ventricular outflow tract throughout diastole. This patient has moderate aortic regurgitation. Note that the color jet is wider than that in the previous case. This patient is in atrial fibrillation with a slow ventricular response. In real time, it will be apparent that the bradycardia increases the time for regurgitation. Mild mitral regurgitation will also be evident. In peristernal short-axis format, the area of the color flow jet again appears moderate relative to the area of the proximal left ventricular outflow tract. In real time, tricuspid regurgitation will also be present. Moving back to peristernal long-axis format, an M-mode cursor has been directed through the aortic regurgitation signals just below the aortic valve. On the color M-mode, mild mitral regurgitation is evident in systole. The aortic regurgitant jet is here. The color M-mode is a nice modality for assessing the width of the jet, as well as for timing of various events during the cardiac cycle. This is a 31-year-old female with rheumatic aortic and mitral valve disease with severe aortic regurgitation. This is a peristernal short-axis view of the three-cusped aortic valve. Note the small central regurgitant orifice. In the peristernal long-axis format, the jet of aortic regurgitation fills the full width of the left ventricular outflow tract. Associated severe mitral regurgitation will also be evident on the real-time display. Note the broad mosaic color jet of severe aortic regurgitation. The M-mode cursor has been placed through the regurgitant jet just below the aortic valve, and the broad jet of aortic regurgitation is demonstrated on the color M-mode throughout diastole. The severe mitral regurgitation is evident in systole. The mosaic jet fills the left atrium. Doctors Perry, Helmke, and Nanda from the University of Alabama, Birmingham have proposed a method for categorizing the degree of aortic regurgitation by color flow imaging. They assess the degree of aortic regurgitation by measurement of the color jet and the left ventricular outflow tract. In the peristernal short-axis format, they measure the area of the jet and divide this by the area of the left ventricular outflow tract. In the peristernal long-axis orientation, they measure the height of the jet and divide this by the height of the left ventricular outflow tract. They have shown that these two quotients correlate nicely with the angiographic grade of aortic regurgitation, while jet length correlates very poorly with the angiographic grade. This is the grading system for aortic regurgitation that Dr. Perry and his colleagues utilized. This is a peristernal long-axis view demonstrating a jet of aortic regurgitation. The image has been frozen in diastole, and the instrument's calipers have been used to measure the width of the jet just below the aortic valve, 9 millimeters. The left ventricular outflow tract diameter has been measured at the same level, 18.8 millimeters. This yields a ratio of 48%, which is moderate by the previously displayed criteria. The transducer has now been rotated to develop a parasternal short axis image. The image has been frozen in diastole, and the area of the jet has been measured by tracing its circumference. The instrument has calculated an area of 126 square millimeters. At the same level, which is just below the aortic valve, the LVOT area has been measured, 404 square millimeters. This yields an area ratio of 31%, which again falls in the moderate category. It is important that these parameters are measured just below valve level, since the jet usually fans out as it extends further toward the ventricle. One should not solely rely on color flow imaging for grading the severity of aortic regurgitation. We always seek supportive data using the continuous and pulsed wave modes. With continuous wave Doppler, we assess the severity of aortic regurgitation via the strength of the signal and via measurement of the pressure half-time of the regurgitant jet. As a general rule, the more aortic regurgitation present, the stronger will be the signal. This patient has mild aortic regurgitation. We had to struggle to define the full velocity envelope in diastole. Note that the systolic aortic signals are much stronger than the diastolic regurgitant signals. This patient has aortic stenosis and severe aortic regurgitation. Note the very dense regurgitant spectrum. In addition to the strength of the regurgitant signals, the diastolic slope of the CW spectrum also gives us important information about the severity of aortic regurgitation. This schematic shows pressure tracings of the aorta and left ventricle from patients with mild and severe aortic regurgitation. The shaded area is the diastolic pressure gradient between the aorta and left ventricle. In both cases, the initial gradient is large, which will result in a high velocity early in diastole, as we will see on the CW spectra. With mild aortic regurgitation, the left ventricular end diastolic pressure is normal. The pressure gradient between aorta and left ventricle at end diastole is still quite large. This means that the rate of change in the pressure gradient is small, and we would expect a prolonged pressure half-time. By contrast, in severe aortic regurgitation, the aortic diastolic pressure is low, and the left ventricular end diastolic pressure is elevated. These two factors result in a relatively small gradient between the aorta and left ventricle at end diastole. Consequently, the rate of change of the gradient from early to late diastole is relatively rapid, and we would expect a short pressure half-time. This patient has mild aortic regurgitation. The early diastolic velocity on the continuous wave spectrum is about 4 meters per second, correlating with the high early diastolic gradient that is always expected with aortic regurgitation. Note that the slope of the regurgitant profile is relatively flat. This slope has now been traced, and the instrument has measured a pressure half-time of 713 milliseconds. Various cutoff levels have been suggested in the literature for classifying aortic regurgitation via this CW technique. We have found that half-times greater than 500 milliseconds are consistently associated with mild regurgitation. This patient has moderate aortic stenosis and severe aortic regurgitation. The end diastolic velocity is low, which implies that there is a relatively small gradient between aorta and LV at end diastole. There is a rapid decrease in the pressure gradient from early to late diastole, as reflected here by the rapid fall-off in velocity. The top of the pressure curve has been traced, and the pressure half-time has been calculated as 165 milliseconds. We have found pressure half-times below 200 milliseconds to be consistently associated with severe aortic regurgitation. Having discussed the utility of color flow imaging and continuous wave Doppler in semi-quantitating the degree of aortic regurgitation, we will now discuss the utility of pulsed wave Doppler in this same context. The amount of diastolic flow reversal in the aortic arch provides insight into the degree of aortic regurgitation. Regurgitant fractions may be calculated by utilizing pulsed wave Doppler and 2D echo to compare flow in the left ventricular outflow tract with flow at various other positions in the heart, such as across the mitral valve. These measurements are quite tedious. We do not routinely use them in clinical assessment of aortic regurgitation. Severe aortic insufficiency will cause a reduction in the mitral valve deceleration time, which is also assessed using the pulsed wave mode. The flow reversal in the aortic arch can be demonstrated by both pulse Doppler and color flow imaging. This is a normal arch examination with the transducer in the suprasternal notch. The cursor in the descending aorta is generating this color M mode. Several cycles show slight, early diastolic flow reversal, encoded in red because the flow is toward the transducer. To accomplish the pulsed wave examination for flow reversal, we most commonly use a sample volume position in the descending aorta about a centimeter or so beyond the left subclavian artery. Here we are utilizing flow imaging to guide sample volume placement. This is the resultant pulsed wave spectrum. Systolic flow is recorded below the baseline. In early diastole, there is a brief signal above the baseline due to a physiologic amount of flow reversal. The remainder of the diastolic signal is below the baseline, indicating that the majority of diastolic flow is in a forward direction. Patients with mild aortic regurgitation might show this same pattern. We have not found this portion of the Doppler examination useful for separating normals from those with mild aortic regurgitation. This 61-year-old female has moderate aortic regurgitation. In systole, flow in the descending aorta is largely encoded in blue. This red area is due to color alias. These same findings are noted in systole on the color M mode. Flow reversal is noted in diastole. Rather than being a very brief color event, the flow reversal in this patient lasts for about 1/4 of diastole. A pulsed sample volume has been placed in the descending aorta. The spectrum shows that the early flow reversal has a relatively high velocity of about 0.6 meters per second. The velocity falls off to a minimum level by about 1/4 of diastole and then persists throughout diastole at a lower level. This latter velocity was too low to be demonstrated on the color examination. This pulsed pattern is typical for a moderate degree of aortic regurgitation. This patient has severe aortic regurgitation. Note the marked pulsatility of the arch. This is another characteristic of severe aortic regurgitation. In systole, the descending aorta is filled with blue-green signals representing forward flow. In diastole, the entire descending aorta is filled with red. This large amount of color reversal is due to severe aortic regurgitation. On the color M mode, note that the marked color reversal persists throughout diastole. On the pulsed spectrum, note that the flow reversal has a velocity of about 0.4 meters per second and persists throughout diastole. This is the pulsed wave examination from another patient with severe aortic regurgitation. As previously mentioned, severe degrees of aortic regurgitation cause a rapid and marked rise in left ventricular diastolic pressure. This not only contributes to a shortened pressure half-time of the aortic regurgitant signal, but also causes a marked decrease in the deceleration time of mitral inflow. The deceleration time here is 85 milliseconds. Normal for adults is greater than 160 milliseconds. This is the mitral inflow spectrum from the same patient following aortic valve replacement. The deceleration time has increased to 225 milliseconds. The effect on the mitral valve of the marked rise in left ventricular diastolic pressure due to severe aortic regurgitation can also be detected by M mode. This is the M mode from a patient with chronic aortic regurgitation. The jet is directed toward the anterior mitral leaflet, creating diastolic flutter, which is an M mode hallmark of aortic regurgitation. In this case, the mitral valve closes with normal timing following the onset of the QRS complex. This is a case of acute severe aortic regurgitation. The rapid and marked rise in left ventricular diastolic pressure has closed the mitral valve prematurely. This is a mitral pulsed wave Doppler spectrum obtained from yet another patient with acute severe aortic regurgitation. The sample volume has been positioned within the mitral funnel. This is the mitral closing click, which is occurring well before the QRS complex. The click is followed by a signal of mitral regurgitation, which begins in diastole and then continues throughout systole. Diastolic mitral regurgitation is another finding that points to severe elevation in left ventricular diastolic pressure. When assessing patients with aortic regurgitation, we cannot rely solely on any one parameter as an absolute marker of severity. Rather, we must integrate all of the Doppler information that we can obtain from the left ventricular outflow tract, from the arch, and from the mitral inflow pattern. In addition, we must not ignore the very important information provided by measurement of the ventricular dimensions. This gives us the functional significance of the regurgitation. This is another patient with severe aortic regurgitation. The M-mode cursor is being passed through the left ventricle at chordal level. The left ventricle is markedly enlarged with a diastolic dimension of 87 millimeters and a systolic dimension of 54 millimeters. This corresponds to an ejection fraction of 65%. In addition to giving witness to the degree of volume overload, left ventricular measurements are critical for serial follow-up of patients with aortic regurgitation. On this tape, we have described the comprehensive echocardiographic assessment of aortic valve disease. For patients with aortic stenosis, meticulous application of the 2D and Doppler techniques that we have discussed will allow you to accurately determine the pressure gradient and the aortic valve area. For patients with aortic regurgitation, the integrated approach we have described, incorporating 2D, TW, CW, and color flow information, will allow you to accurately characterize the hemodynamic severity. Therefore, it is only a small minority of patients with aortic valve disease that now require invasive assessment of hemodynamics for clinical decision-making.